Hello and welcome to the PrecisCa Multidisciplinary Genitourinary Tumor Panel. My name is Jason Abel. I'm a urologic oncologist at the University of Wisconsin. To begin, we'll just go around the panel, introduce yourself and your expertise. Dr. Melnick.
My name is Vincent Melnick from Washington University in St. Louis, and I'm an abdominal radiologist.
Hi, my name is Matt Reddick. I'm a medical oncologist specializing in genitourinary malignancies.
I'm Larry Keston, a radiation oncologist in the Detroit, Michigan area. I'm the medical director of the Michigan region for MHP Radiation Oncology Institute and Genesis Care.
Yes, I'm Ethar Derwish. I'm a urologic oncologist at the University of California, San Diego.
We have a 57-year-old gentleman who's diagnosed with de novo metastatic renal cell cancer. He completed 2 cycles of ipilimumab and nivolumab and 1 cycle of nivolumab with repeat scans showing significant progression. The sites of progression include the lung, the liver, and the adrenal glands. And so the question that we're going to discuss is what are the recommendations for next steps in treatment. Dr. Melnick, could you comment on the radiographic findings here?
Yes, thank you, Dr. Abel. This is one CT image through the sort of mid-chest, focusing on the lungs. And you can see that in both lungs, there are round nodules on both sides, the largest there on the left side posteriorly. The size and number of these lesions is certainly concerning for metastatic disease, given the known history of renal cell carcinoma, which does tend to metastasize to the lungs. I think there's a second slide of imaging as well. So this is one a CT image in the coronal plane. This is sort of looking front to back rather than looking at the body cross-sectionally. And there's a large mass in the right upper quadrant of the abdomen. It is occupying portions of the kidney, extending into what we call the suprarenal fossa above the kidney, involving the adrenal gland and also into the right lobe of the liver. So fairly extensive local tumor burden as well.
So Dr. Derwish, is there a role for surgery in this patient at this point?
With metastatic disease that's bulky in this situation, unfortunately, there really isn't. I mean, we could always consider consolidative surgery if they have a response after second-line therapy. But at this point, with this amount of disease, the morbidity of an attempted surgical resection would be very, very significant, and would probably hasten a patient's demise and make a more rapid course of clinical deterioration afterwards.
So Dr. Reddick, this patient was treated with combination immune checkpoint inhibitors as a first line, and he's now failing in multiple sites. Could you discuss how you approach treatment selection for second line treatments?
Sure. First of all, I think it's important to recognize that the immunotherapy, the dual checkpoint inhibitor approach is really an excellent approach in those patients who have a profound response, sometimes even a complete remission. These remissions can be very, very durable. In this case, the patient has radiographic evidence of the pre-existing metastases getting larger. There is a phenomenon called pseudoprogression, whereby, especially in the early stages of immunotherapy treatment, in the early months, there can be an increase in the size of the lesions that actually doesn't represent the cancer getting worse, but rather represents a phenomenon related to the immune therapy, which is that immune cells are infiltrating the tumors, the metastases, and causing the images on the scans to look worse. I think what we generally want to know is whether or not the patient has symptomatic progression, because even if there's in the presence of symptomatic progression, then this phenomenon of pseudoprogression is very unlikely, and it probably the enlarging metastasis probably represents true disease progression. So that's really a critical first step. If this patient is asymptomatic, what I would do, or without progression in symptoms, what I would do is continue the immunotherapy for now and repeat another set of scans in at least 4 weeks, probably closer to 8 weeks, to see if there's further progression. If there was further progression, then yes, I would abandon the immunotherapy and move to a second-line therapy. So getting to the original question is, what is the second-line therapy? Given that the patients already had immunotherapy, the further immunotherapy options are really not viable. So we would switch to one of the targeted agents, namely those agents that target the blood vessels, we call the angiogenesis inhibitors. One that is particularly useful and can improve outcomes is one called cabozantinib, but there are several others that can be used in this particular setting that could be effective. And these are oral agents. They do have side effects and potential complications, so one must be mindful of the patient's underlying conditions in trying to mitigate any side effects related to these targeted agents.
Is there ever a role for genomic profiling in these type of patients?
Yeah, yes, there is a role. There's different types of genomic profiling. There's the genome profiling of the tumor itself, and all tumors have genetic changes, mutations. In kidney cancer, it's rare to find a mutation that is actionable, that is a mutation that can be paired with a therapy. But if the patient is running out of choices for therapy, it's reasonable to perform genetic sequencing on the tumor tissue to identify potential mutations that can be targeted, but with a low expectation that something would be found. If the patient had a personal history of multiple cancers, or a family history that would suggest a hereditary cancer syndrome, then testing for a hereditary cancer syndrome, what we call germline testing, germline meaning that the patient was born with the mutation, would also be recommended, because that can identify mutations that are also actionable in pair with the drug, and would also, if there is a germline mutation, result in what we call cascade testing, where appropriate family members can be tested for the same hereditary cancer syndrome and undergo appropriate screening and preventive measures if they were to have that mutation.
So for a 57-year-old, otherwise healthy patient with metastatic renal cell cancer who progresses in multiple sites after first-line combination immune checkpoint inhibitor therapy, the multidisciplinary panel discussed the next steps to consider would be consider whether this was pseudoprogression from immunotherapy and whether the patient was symptomatic. If the patient was symptomatic or repeat imaging in 2 months shows progression, then cabozantinib or another second-line treatment may be appropriately recommended.